I'll tell you.
Okay, so welcome everyone. My name is Lisa Roberts, and I'm a member of the North Andover Parent Resource Network. Due to some technical difficulties this fall, when we did the original presentation, we're re-recording with just 3 of us present so people can see the presentation, Eating Disorders, the Silent Epidemic. The NAPRN was revived this year in response to a huge increase in mental health awareness and support needs. Evidence shows how important social and emotional skills are for our kids, and students learn these in the schools, and our goal is to extend this learning to the home. So we do this through speaker series and monthly small discussion groups, and they're all posted on our website, www.naparentresourcenetwork.org. Tonight's topic is sponsored by the North Andover Youth Center, and we're very grateful for their support. If you'd like to donate or know a business that would, again, visit our website, naparentresourcenetwork.org. So before we begin, I just want to remind you that this can be a really tough topic and it may bring up some intense emotions. Please practice self-care, and if you need to take a quick break, you can just hit pause and step away. Tonight, we have the honor of hosting Dr. Michael Cumianto, an expert and savior in the eating disorder realm. Personally, this is an important topic for me to bring to the parents of North Andover and surrounding towns because it hits very close to home. A couple weeks before the pandemic shut everything down, we were dealing with another emergency in our home. My oldest daughter, at the time a freshman in high school, had just been admitted to the hospital with an eating disorder. At that point, she was at her lowest weight and refusing most food. Her brain had become so malnourished that it was actually telling her not to eat. It was the scariest time of our life. In that time leading up to her hospitalization, she'd gone from a very social teen who loved meeting new people to an introvert who was timid and quiet. She started the habit, new to her, of cooking and watching us eat it. She kept to herself, and while playing volleyball, went from loudly cheering her teammates on to standing at the end of the line of players with arms drawn in. Her grades had begun to slip, and she seemed to get sick a lot. We took her to the doctors because she had picked up yet another cold, and we were concerned. As the words came out of the doctor's mouth, "Your daughter has an eating disorder," everything came crashing together and made sense. Now we found ourselves in what felt like a scary hole looking up. No one talked about eating disorders. It was nearly taboo to discuss. Had we known the warning signs, we could have caught this much earlier and likely not needed such high levels of care that she required. Today, I'm happy to say she's doing really well and encouraged me to start telling her story so we can help others. Which leads me to the amazing person we have here tonight, Dr. Michael Cumianto. He was part of the team that helped my daughter recover. Dr. Cumianto is currently the Director of Adolescent Services at Walden Behavioral Care. In this role, he provides clinicians and families with the training and resources necessary to employ evidence-based interventions for adolescent eating disorders. Dr. Cumianto has received advanced intensive training in FBT, which is family-based treatment, and DBT, dialectical behavior therapy, two empirically validated treatment models for the adolescent population. Dr. Cumianto speaks on eating disorders, suicide, FBT, DBT internationally, and provides consultation and coaching to parents, caretakers, educators, and healthcare providers. Welcome, Dr. Cumianto, and thank you so much for agreeing to redo this recording.
Thank you, Lisa. The objective here, as you know, and hopefully this will be helpful to everybody who's watching, is to just put out some information that might help people clarify some of the misconceptions of eating disorders, facts, fiction, and how to help. So we're going to start with some things that are often misunderstood about eating disorders, and then we'll wrap up with some suggestions about how adults and other teens can help somebody that they're worried about. Eating disorders are not a choice. Often people come into our care either blaming themselves or blaming someone else and suggesting at the early stages of treatment that somebody could either choose to engage with their eating disorder or simply choose to get better. And what we know is that there are a variety of factors that play into somebody developing an eating disorder, and it isn't a situation where someone's deciding. There might be things within the course of treatment or within the course of the disease that people can choose to help themselves along with or receive help with. But in general, we want to remember that the eating disorder itself is not a decision that someone's made. So if somebody seems hesitant for treatment, that's a given in this problem. And we want to be approaching them as if this is something that is controlling them, something that happened to them due to a number of factors and not simply by choice. It's also misunderstood in a lot of situations that not all eating disorders involve concerns for weight, shape, and size. Typically, when people think about an eating disorder, they'll think about anorexia specifically. And there are eating disorders that we have now in our diagnostic system that have nothing to do with appearance. And it's important that people keep that in mind because we could miss something if we're looking or listening for somebody just commenting on their own weight or their appearance. Unfortunately, ideas and recommendations specific to healthy eating are not always clear and consistent. As people know, we have a lot of mixed messages in our world, in our media. We hear a lot of different things from doctors, professionals, non-professionals, etc. What healthy eating means to me may be totally different for you. We all have different ideas about it, and there's no one way of eating that's consistent or clear. So we have to acknowledge that when somebody's struggling with this problem, that it often can be a result of hearing so many different messages about what healthy actually is. An adolescent's understanding of the importance of proper nutrition does not usually correspond with progress in treatment. This really speaks to the fact that an eating disorder in many ways is not a logical problem. Typically, this is not an error of logic or a misunderstanding. People know what proper nutrition is and that they need to eat. That knowledge is not the issue. Eating disorders are very much an emotional and biologically based behavioral problem. So we want people to know that simply educating somebody about why they should eat or what they should eat will not necessarily lead to progress in treatment. Contrary to previous beliefs, parents and other family members involved in the care of an adolescent with an eating disorder are likely to have a positive influence and are no longer considered a source of blame. In the early stages of eating disorder treatment, people would often recommend that family members not be included in the care. And now we're in a radically different place where family members, even for adults in a lot of cases, are being pulled in to help. Eating disorders do affect nearly every organ system in the body. Often we're thinking about how the person changes on the outside and maybe how they change in their behavior and their thoughts. But we have to acknowledge the effects of the eating disorder on the entire physiology of the person. The cardiac system, the nervous system, the size and shape of the brain, and all of the organs and chemicals within our body are changing when we're not eating in a way that helps us to thrive. This could be undereating, overeating, anything that affects your blood sugar, and anything that affects the level of nutrients and lab values that you have in your body. So when you're looking at somebody or talking to somebody with an eating disorder, it's important to remember that their brain is functioning differently, their heart is functioning differently, and because of that, their entire physiology is dysregulated. Teens with eating disorders, as confusing as it can be, may continue to excel academically while they're being significantly affected by the disease. This is so confusing to adults involved in people's care, particularly at schools, where we might see a student doing really well. They could be excelling academically, maintaining straight A's. They may even be excelling physically in athletics. But that does not mean that the eating disorder is not having a severe effect on them. Often people will report feeling like they were at their highest functioning until they weren't. So if you're aware of an eating disorder or suspecting an eating disorder, we can't necessarily depend on that person's athletic or academic performance to speak to the severity of the problem. Many people believe that if a male is struggling with an eating disorder, it's either due to the influence of athletics and working out, or it's an identity related problem. And we've seen that that's not the case. Boys with eating disorders often have many of the same precipitants that females have. They may present with the same body image concerns, the same emotional stressors, and the same characteristics that we see with all genders. So it's important to remember that the eating disorder does not necessarily affect any one particular gender in a specific way. Eating disorders can develop as a result of other life events that cause decreased appetite or weight loss. So what this means is that somebody could lose weight or lose their appetite for any reason. It could be a medical problem, it could be COVID, it could be the flu, it could be dental work, it could be any severe medical problem that results in weight loss or decreased appetite. This can then develop very quickly into an eating disorder. This is important to know because often we normalize the fact that people can lose their appetite or lose weight during a medical illness, and that the eating disorder can come in at that very point. So as soon as somebody is recovering from that medical problem, we need to be vigilant for any eating disorder symptoms that might continue after the medical problem has passed. When someone is struggling with an eating disorder, it's recommended that they remain aware of their weight. This is a point that's often protested against, both in the eating disorder field and the general community. All of the evidence-based treatments for eating disorders recommend that people know their weight and are seeing their weight when they're being weighed on a scale, whether that's at the doctor's office with a dietitian or in a treatment program. People being blind to their weight often reinforces the idea that the weight itself is the problem and something to be feared. It also can send the person the message that they'll never see their weight again, or that they need to show some sign of readiness that often isn't defined. Specialized outpatient individual therapy is not the most effective treatment for an adolescent with an eating disorder. What we know now is that individual one-on-one therapy can help with a range of other problems surrounding the eating disorder. It can help the adolescent feel heard and understood in the way that they talk about the eating disorder, but that on its own will usually not affect change in the bigger picture. What we need is a family intervention and a group intervention in addition to individual treatment. There is no clear definition of recovery from an eating disorder. This is extremely confusing to people who are struggling with it and people that are trying to help them. We often ask people about their motivation to recover. We ask them what recovery might mean to them, but it's helpful for everybody to know that if we're thinking about recovery as very specific criteria, there really isn't. And that might be a problem in the field. It might be something that's in development, but where we are right now, we're actually asking people to just take steps towards whatever it is the recovery means for them. And for most people, recovery is going to translate into a life that's not held back by the symptoms of the eating disorder. Returning to normal school, social, and athletic functioning and having the life that they want is what most people would consider recovery, rather than this larger idea that's yet to be defined. Eating disorder symptoms can cause or increase symptoms of anxiety, OCD, and depression. Often people will wonder if eating disorders are a manifestation of anxiety or if an anxiety disorder causes an eating disorder. Usually we're thinking about this in the opposite way. We know from research that eating disorders exacerbate symptoms of anxiety, that the isolation that comes with an eating disorder can lead to increased depression, and that people in severe stages of an eating disorder will show OCD symptoms that weren't there previously, often symptoms that don't even relate to food or weight or eating itself. We'll see people hoarding things, organizing things, getting very hung up on details. And even though some of that might have been characteristic throughout their lives to a much smaller degree, the eating disorder usually exaggerates it. And so while anxiety, OCD, and depression can't cause an eating disorder, eating disorders can cause those. So when we're seeing all of those at the same time, the point is that we have to treat the eating disorder in order to reduce those other symptoms. Eating disorders are not typically a result of a variety of underlying issues. This is important if we're trying to get at the root cause of the problem. And when we're dealing with somebody that needs help with an eating disorder, we really want to remember that the eating disorder is the problem in that moment. It can be very distracting and very, complicated to try to figure out what's really going on underneath it. And while we're doing that, we're often seeing the eating disorder get worse and worse. So some people will say they don't know how the eating disorder came to be, and they actually don't need to. Any understanding of what led to the eating disorder is not necessarily going to have an effect on the course of treatment or whether or not the person continues to stay in a good place after treatment. We want them to be aware of the things that may have contributed, but we have to be careful to not dig something up that isn't there. Twins and triplets are statistically more likely to develop an eating disorder. We don't know why that is. People have theories about comparisons and about the pressure on twins to be individuated and to have their own identity and things like that, but we don't really have a clear answer. What we do know is, just statistically speaking, we do see twins and triplets presenting for treatment more often than we do people who are not. And that's unclear, but still being researched. Eating disorders are not more common in affluent communities. This is important for people that might think that the eating disorder is a problem for rich white people or people in a specific community or a specific culture. We see eating disorders all over the world. We see them in a variety of socioeconomic statuses, and they don't seem to be dependent on any one particular part of culture. So important to remember that when we see eating disorders, we're seeing them all over the world, every age group, every gender, and every socioeconomic status. Previous to recent times, people were considering eating disorders to be exclusive to a more privileged population, and that was really never the case. Someone who chooses not to tell you about their problems with eating does not necessarily distrust you. This is a situation where ambivalence is a given. People often feel a great amount of shame and guilt related to their eating disorder, and they know that disclosing their eating disorder could be confusing or anxiety provoking for other people. So often their intention is to not burden other people and to keep the problem to themselves, because they're aware that if they reveal it to others, they might be encouraged to go into treatment and may not feel ready. So we just want everyone to know that if somebody's not being forthcoming with you about the problem, it does not mean they don't trust you. There are currently no specific medications known to resolve eating disorder symptoms. We know certain medications can help take the edge off of certain symptoms, but there isn't one medication right now that's indicated as a first-line treatment for eating disorders. Most eating disorders do involve some degree of restricting behavior. Even though eating disorders do not necessarily need to include concerns for weight, shape, and size, the behavior of restricting is consistent among most eating disorders or across most eating disorders. So somebody who's struggling with binge eating is probably also restricting. Somebody who's struggling with purging is likely also restricting. And it's rare when we see an eating disorder that doesn't have some amount of restricting behavior in it. Eating disorders are not, in fact, caused by an urge for control. This is a previous theory on eating disorders, that people were trying to find control in any area they could, and that the only thing that they could control was food or their weight. In fact, contrary to that, many people with eating disorders will describe feeling out of control or feeling like the eating disorder is controlling them. So when we're looking at somebody with an eating disorder, we have to know that by the time we're aware of it, and by the time the person is asking for help or getting help, the problem often seems bigger than them, like it's taken them over entirely. And if we see somebody as simply looking for a way of controlling something, we might miss the level of intensity or the level of severity. So when you're seeing it as control, just imagine that the person is actually being controlled as if a disease is happening to them rather than them choosing it or using it as a method of control. Over-exercising without decreasing food intake does and can meet criteria for an eating disorder. We see a lot of people now, obviously, obsessing about exercise, just like we do with food. We get a lot of mixed messaging about exercise. People feel very stuck when they have to go outside of their normal exercise routine. We're not thinking about the typical level of exercise that helps somebody maintain a positive mood and a healthy overall, physical and mental health. But when the exercise is excessive, even if they're not decreasing their food intake, that can meet criteria for an eating disorder because it's considered a compensatory behavior. Adolescents with eating disorders show decreased brain volume, but can recover when treated. Adults who have the same changes to the brain may not recover or may not recover as quickly. I think it's important for people to remember that when somebody's struggling with this disease, their brain actually looks different. And we might be seeing the changes on the surface. We might be hearing the changes in their thoughts. We have to remember that this problem is not a simple one to solve because, as we covered previously, it's affecting every organ system and the brain may actually be shrinking. So not just what we see on the surface. We know that certain sports, without intending to, can reinforce the significance of a specific weight to position and performance. So often we see people in treatment who felt pressured to maintain a certain weight, to either lose weight or gain weight, or be in a certain role on their team, and that can lead them to behaviors that ultimately stick and develop into a bigger problem. So we would never blame the sport or the fact that somebody's an athlete for the eating disorder itself, but we really want to be looking everywhere we can for what might be sending message to the adolescent that they need to maintain a certain weight or lose weight. Body mass index, or BMI, is not at all the most accurate measure for children and adolescents. In fact, more recently, BMI is being considered less and less relevant when we're evaluating people's health, particularly for people that are not done growing, and particularly for people that have not been historically average for weight and height. For anybody that's been smaller or larger than their peers historically, BMI is not going to really capture the relationship between weight and their health. That's because an individual can have a quote unquote healthy BMI and also be underweight. The parameters for diagnosing eating disorders used to include somebody being at or below a certain weight to meet criteria. That's no longer the case. So we have to be careful to not try and evaluate the status of someone's eating disorder on their BMI or their weight alone. There are no current evidence-based treatments for body image itself, but there are current evidence-based treatments for eating disorders in general. So often people will target specific symptoms like body image when we need to target the eating disorder as an entity. Once the eating disorder is treated effectively, concerns for body image and other thought disturbances will resolve. Adolescents with eating disorders can actually improve quickly in treatment if they're treated as early as possible. So when somebody is struggling with an eating disorder, it's really important that we get them seen by doctors, dietitians, and therapists as quickly as possible, and ideally get them involved with a family-based treatment as quickly as possible. This isn't something that's going to resolve itself. It's not a phase that somebody's going through. And the longer we wait, the longer the person may struggle. Adolescents who are restricting and have lost weight cannot recover cognitively and emotionally without restoring that. So if somebody's losing weight and has changed their entire physiology, we can't really expect to see cognitive or emotional improvements until that weight is restored. Often people try and conceptualize it in the opposite way. They might suggest that somebody work on their mood or their thoughts, and then the weight will fix itself. And it happens to be the other way around. We need somebody to be physically healthy from the inside out in order to change their thoughts and their emotional presentation. Many people don't know that the brain is made of at least 60% fat. So when somebody is not taking fat in and doesn't have fat in their diet, it's affecting their brain. And that, we think about fat on our bodies, but we don't think about it in our bodies. And so fat isn't just something that is included in food or that we might consider when we're looking at somebody's BMI, but the human brain itself needs a certain amount of fat to remain healthy. There are, thankfully, evidence-based treatments for adolescent eating disorders, and those are generally family and group therapy based, not individual therapy alone. So the good news here is that if you do know an adolescent that's struggling, there are treatments that are considered to be gold standard for them. That's not so much the case for adults. So when we see somebody at a young age struggling with this disease, we want to get them in treatment as quickly as possible so that they can get the treatments that are proven to be effective for them. If they struggle for years and years and years and end up being adults in adult eating disorder treatment, the outcomes just aren't as good. A traumatic experience is not considered a direct precursor to an eating disorder. In the past, people have assumed that if somebody develops an eating disorder, they must have experienced some type of trauma. This is very similar to the way that we think about the so-called underlying issues. There are people with trauma who develop eating disorders, and there are people with trauma who do not. And the majority of people who get diagnosed with eating disorders do not have a trauma history. Gender dysphoria and eating disorders are highly correlated and increased risk, both for suicide and the eating disorder itself. So when you're caring for somebody that's struggling with gender identity, you want to keep in mind that that is a risk factor and that can exacerbate the symptoms of the eating disorder. It wouldn't cause the eating disorder, but there's a large overlap. Early or late puberty, or being historically larger or smaller than peers, those individuals can be more likely to develop an eating disorder. This speaks to the BMI issue as well as identity issues. If you've always been larger or smaller than your peers, or you've developed faster or slower than your peers, it may increase attention to your body. It may make you more self-conscious. And for other reasons that we don't know about, early or late puberty is often correlated to the development of this disease. Many people don't know that eating disorders are actually the most lethal of all psychiatric problems. So compared to adolescents who are struggling with substance use or depression or bipolar disorder, eating disorders are more likely to end in a fatality than any other psychiatric problem. Most people with eating disorders will fall out of the 50th percentile for weight and stature. So when we're trying to treat somebody struggling with this problem, it's important that we don't just shoot for what would be considered an average weight. A teen without an eating disorder can actually improve, even if they're not expressing motivation to change. This is very confusing for people. Often we'll hear people who are struggling with an eating disorder say that they want to get better and don't want to get better at the same time. We don't necessarily need to wait for their cue or their expression of motivation and readiness. They can make progress even if they're still ambivalent about getting help. Many adolescents with eating disorders are not satisfied by reaching their lowest historical weight. They'll tell us over and over again that they could have gone lower, would have gone lower. And this is important because sometimes uh, we'll think that somebody bringing the eating disorder to a certain point will be enough, and that would be their rock bottom. There really isn't such a thing as a rock bottom when it comes to eating disorders. People will continue to engage in eating disorder behaviors and will continue to lose weight until they're treated. And before we wrap up and get into how to help somebody with an eating disorder, I wanted to make sure that people were familiar with terminology. Most people understand what anorexia means, but anorexia no longer includes criteria specific to weight or menstruation. We know that anorexia can affect all genders and all ages and all weights. So we have to be careful to not consider anorexia in one specific way. The diagnostic criteria have been expanded, and that includes what we now refer to as atypical anorexia. Atypical anorexia might be categorized as an unspecified eating disorder, but this is usually the way we describe people who may, quote unquote, look normal. They may have historically have had a larger body frame, or they might have been taller or at a higher weight than their peers. So somebody might not necessarily be able to tell. These are also the individuals that would go into a doctor's appointment and maybe be encouraged to lose weight, or they might not be flagged as a concern when they lose weight. But they're engaging in the same behaviors that anyone with anorexia would, and the physical and psychological effects are the same. Bulimia includes binging and purging behaviors, but it can also include purging behaviors that we don't think about. Behaviors like overexercising are considered purging. Usually when we think about purging, we think about vomiting. But anything that's a compensatory behavior that sacrifices a person's caloric intake or their ability to maintain a healthy internal physiology, healthy blood sugar, or healthy weight is considered a compensatory purging behavior. Most people are becoming familiar with ARFID as a diagnosis. ARFID stands for Avoidant Restrictive Food Intake Disorder. This is when an individual has historically struggled with variety, or they might have been described as difficult to feed or failure to thrive. These people may not be concerned for their weight, their shape, or their size. In fact, they might know that they need to gain weight in order to develop, on a developmental trajectory that makes sense for their age. But they struggle to do that because there's something about eating that's aversive to them. It could be the texture of food. It could be the colors of food. It could be that they're just not getting specific foods that are keeping them nutritionally stable. So we treat ARFID in a very similar way to the way that we treat anorexia, but there are some things that are done differently. It can affect a younger population. It can be noticed younger, and people may have more motivation to change because they're aware of the problem in a different way. Binge eating disorder was recently added into the diagnostic system. Previous to this, it was categorized as unspecified or another disorder of feeding and eating. We now have treatments and diagnostic criteria for binge eating, and we see it in all age groups. In fact, binge eating disorder is the most commonly diagnosed eating disorder. Most people imagine anorexia or bulimia, but binge eating is the most common eating disorder in the diagnostic system. Orthorexia is not a formal diagnosis, but this is something that's often referenced when we think about people that have an obsession with healthy eating or clean eating, or they're engaging in some type of eating behavior that's like a fad or advertised in popular culture, but they take it to an extreme level. So these are people that may only eat fruits and vegetables or whole foods, or they might be following a diet that's considered at the time to be the most healthy diet, and they're just taking it to an extreme level. OSFED and UFED are acronyms for other specified eating disorder and unspecified feeding and eating disorder. So this really just depends on the symptom presentation and the person who's diagnosing them. These are often used when we need more information or when somebody appears to have all of the symptoms of all of the diagnoses. Usually we change the diagnosis over time when we get more information, but these are representative of what used to be called unspecified eating disorder. The behaviors included in eating disorders include restricting, purging, and other compensatory behaviors, including exercise, avoidance behaviors, whether that's avoiding certain foods, certain textures of foods, or avoiding things like mirrors, being seen, etc. Picky eating is often considered a characteristic of ARFID, but we see it across eating disorder diagnoses. Usually by the time somebody meets criteria for an eating disorder, it's gone beyond picky. So we want to be careful to not think about it as just that. And then when we're talking about binge eating, it's important to note whether that binge eating is self-reported or reported by other people. Some people will say that they're binging when in fact they're just snacking. Some people will say that they're binging when they're overeating. But binging behavior is very specific, and it usually describes somebody who's eating a large amount of food in a very short period of time and feels out of control while they're doing it. So one of the major points here is that it's not about whether the eating disorder was caused by anxiety. Eating disorders are not anxiety disorders, they're not thought disorders, they're not OCD, they're not trauma disorders, and they're not necessarily the result of a parent with an eating disorder. We have lots of parents who struggle with eating disorders that don't have kids with eating disorders and vice versa. So it's important not to pathologize parents and not to think about the eating disorder as a manifestation of one of these other problems. The cause does not necessarily relate to the solution. Things that do correlate with eating disorders are family history of addiction, family history of OCD, being a twin or a triplet, having early or late puberty, being failure to thrive in early childhood, or difficult to feed in early childhood. So we want to think about a combination of biology, genetics, individual psychology and temperament, and social factors as the perfect storm that can result in somebody struggling with this problem. I think I'm going to jump to what we do when we're worried about somebody. If people are concerned about the other research-based slides, I can certainly send those along. But I think for the purposes of the school and the people viewing this video, we want to move into what's helpful for people when we start to see them struggling. So when we've organized some of these presentations, we've asked clients in our program, what would they want us to tell other people? And these are the things that they say. They say, make sure to let everybody know not all eating disorders look the same. They want us to be aware of social media and the lifestyles advertised by celebrities. They want us to know that you can't tell whether somebody has an eating disorder by looking at them. They actually make a point to let us know that we should be aware of if people overdoing it with sports and physical activity, that this might be normalized in our culture, but could actually be a symptom of the disease. They want us to know that a lot of what we learn and say about health is wrong, and that we need to stop putting focus on calories. When we're trying to help them to be friendly and supportive and to not go into panic right away. And their choice of words you can see on the bottom. They feel really strongly against healthy eating and healthy BMI in the dialogue around this problem. So it's important that we stay educated and informed. We want to ask doctors about growth and development for that specific individual. The goal is to be an informed consumer, to look at all of the messages we get about health and dieting and physical activity through a critical lens. There are things that are true and there are things that are fabricated, and nothing that we're seeing, unfortunately, is 100% all the time. We want to be able to share observations and assumptions and understand the difference. Know what you're seeing versus what you think. Very important to not jump to conclusions about the person or the severity of the problem, but to share with them what you see. Phrases like "I've noticed" can be very helpful when we're trying to get somebody on board with treatment. We can't overinterpret the symptoms or the things that they're saying. Just start with what their words are and what you're observably seeing. We definitely want to ask parents and others involved if they've noticed any changes in the individual. So sometimes we might try and talk to the individual one-on-one about it, ask them about their own insight related to the problem, but we really want to look to the environments that they're in the most, specifically the home environment, to see not necessarily if the parents have diagnosed the person or if the person meets criteria for the diagnosis, but just have you noticed anything about the child that's been different? And it's important to ask for help when the thoughts and behaviors begin. The sooner that it's caught, the better. So as soon as you're noticing anything that might fall into this category, as soon as the person is noticing anything in this category, we need to act on it. This is not something that we want to wait on. Some pointers when we're trying to help people are to not diagnose immediately. Whether you're a professional or not, we can't diagnose until we have all of the information, and we don't need the diagnosis to start the helping process. So look at the things that people are saying, the way their behavior has changed, and speak specifically to that. We don't need a diagnosis right away, and we often misdiagnose when we don't have enough information. It's important to not over-assert or scream our care and concern. Often when we're worried, as parents, as providers, as caretakers, we get very activated and we might come off as blaming or angry when in fact we're really scared. So we have to regulate our own emotions and communicate our concerns in a gentle but direct way without becoming overly panicked or leading the person to feel as though we're angry at them. Avoid over-educating the person. As I mentioned earlier in the presentation, this is usually not a problem of logic. Most people struggling with eating disorders logically understand the way to eat, what to eat, and I think now, more than ever, we have more education than we need about calories and food ingredients and all of those things. So try not to overwhelm the person with logic and attend to the way that they're communicating their emotions to you. Definitely ask for help with helping. So if you're in a position to talk to somebody about this problem or to ask them questions about it, or you think that somebody needs help, open up to other people. Usually there's going to be someone in your community, someone in your network, someone who's also got a relationship with the person who has similar concerns, where you can reach out to treatment providers, treatment programs, medical providers, and ask their direction, ask for them to collaborate with you, give you more information, and take the appropriate steps. You can offer telling somebody together with the person that you're worried about. So whether that's teaming up as two people that want to talk to the individual, or meeting with that individual so that they can share with somebody else. A team effort is often needed in this situation. And when people are hesitant to disclose, we want to help them and align with them so that we can be a support as they're doing that. Important not to alienate the person. And usually the way we would alienate somebody is if they experience us as over-emotional or blaming or suspicious, or if we're coming on too strong about what they need to do differently. Again, we want to start by sharing our concerns and observations in a fair, gentle, but direct way. And also, it's important to mention here to not avoid the person. Sometimes, even though we don't realize it, when we notice that somebody's struggling and we feel overwhelmed, we might avoid the problem or avoid that person because of that overwhelm. We can't assume the role of the therapist if we're not in the role of therapist with that person. And this goes for therapists. Sometimes therapists will act like therapists to people who they're not providing for. And so we want to act like a neutral person in a general caretaking role in order to give the person the most genuine version of ourselves. Most people don't want to be therapized or lectured or spoken to in an overly therapeutic way with somebody who's not in that role with them. So the idea is to mix being gentle, interested, direct, validating, and using an easy, relatable manner. You know, we're all human, we all have problems. This is not a statement on anybody's character or personality. This is a symptom of a disease, and we want to help them with it. We definitely don't want to move them into a position to be defensive or to isolate them even further than they already are. This is usually when we would ask people for questions and comments and discussion. And when we're doing this presentation live, we usually get a lot of that. In fact, sometimes we've had to schedule a part 2. But given that this is a video, I'm going to pause here and see if there are any concluding comments from your hosts. And we'll go from there.
Thank you, Michael, so much. And I learn something every time I hear you talk. It's amazing. So thank you. I don't have anything to add. Do you have anything to add, Nikki?
I don't. I just like to say thank you as well. Same thing. Every time I hear him speak, I am reminded or learn something new. So I appreciate very much the presentation. And I hope a lot of people get to watch it and learn more about eating disorders.
And I would encourage anybody to feel comfortable reaching out. My email address is here. If you're worried about somebody, if you want to get involved, if you feel like maybe you're stuck and you've explained your concerns to somebody and you need to move on to the next step, or if you're just curious about what treatment options are, I'm happy to help.
Thank you, Michael. And I also want to say people can look at our website because we have a lot of resources. And if Michael's okay with it, we'll add his presentation up there as well, along with this video, because there is a lot of great information in here.
Thank you.
Thank you.